we'd like to invite you for the session on Strabismus and Neuro Ophthalmology Sub-speciality Session 2, Comitant Strabismus. And the first talk will be by Dr. Ankur Sinha, how to reach your amblyopia goals. Thank you.
Thank you, AIOS, and thank you, everyone. So this is going to be a brief overview of amblyopia. We all know how to reach the goals of amblyopia, and I'll be just, so there's suppression going on. Can we have the slides, please? So they were there, and then the moment I clicked, it just went off. So that's what the amblyopia is.
The patient sees nothing, and we also see nothing.
So we feel that the patient is seeing, but when the other eye opens, the कनेक्टर दूं तुम अभी कितनी देर से लगा रहे हो एक मिनट अरे दोबारा लगाऊं
I'm working in Assam. I'm affiliated of the Congress in Strabismus. You are in Denmark.
In Copenhagen. Oh, that's nice. What's he doing there?
He's in Nordia Bank.
Nordia, yes, the big Nordic.
I think
Nordic
can we have the next speaker till the time they fix up the issue? Then I can maybe
The next speaker
Maybe on the-
is Suma Ganesh. Is she there?
So Sandra Ganesh, who's going to be speaking on acute comitant esotropia investigations and management.
I hope my luck is better than yours, Dr. Ankur. Yeah, it is.
I think it is about multimodality.
So I'll be,
Yeah, she's already
thanks for
there.
the invitation. And I'll be talking on acute comitant esotropia, investigations and management. So to begin with, we all should understand that it's a very rare type of strabismus in 0.3% of children. It's characterized by acute onset, large angle. Initially, it may be intermittent and then comes to constancy. And usually, it is present in older children and adults. So many people with acute onset of esotropia have uncorrected myopia, and there is oftentimes associated with excessive near activity. So we notice that there is a decompensated esophoria in few people. So initially, they may have progressive, intermittent, horizontal or binocular diplopia that then dramatically converts into a constant large angle esotropia. Sometimes it can also be associated with intracranial diseases like brain gliomas or Arnold-Chiari malformations, and these could be etiologies. So the etiology is still not completely understood, but it can be associated with excessive near work, which could produce an imbalance of convergence and divergence tone of the extraocular muscles. So the classification initially was given by Swan et al. Into 3 types, and this is the most comprehensive classification by Buck et al., where type 1 is the same as Swan's, occlusion related. Like some patients, say that they do occlusion and then they notice esotropia once they remove the cover. Type 2 is the Burian transiety type, which is non-accommodative, precipitated by physical or psychological stress. Type 3 is the acute comitant, sometimes associated with hyperopia, and we can control this by wearing glasses. Type 4 is a decompensated ACE, monofixation syndrome or ESO. Type 5 is associated with intracranial pathologies. Type 6 is cyclic ACE, and type 7 is the secondary ACE. So now in the recent 5 years, we have noticed an increased incidence of ACE all over India. And this ACE related to COVID era does not usually meet the diagnostic criteria for the 3 main types. Most of the patients, it's associated with a smartphone usage of more than 4 hours a day. And everybody who uses smartphones does not face this problem. So it mainly occurs in adolescents who have a low divergence capacity or a previous latent esophoria. And that leads to a dramatic overaction of medial rectus, and that results in the manifestropias. So this was a study which was published where they compared the incidence of ACE to IXT from the years 2007 to 2021. So here you can see that the proportion of ACE to IXT has comparatively increased from 0 in 2007 to 5.88 in 2021. So that in children, it leads to amblyopia. The longer you wait with this misalignment, it can lead to amblyopia, where in adults, it leads to intractable diplopia, which was so beautifully illustrated by the previous speaker. This was a recent study published in JPOS 2023, where they talk about the clinical profile of around 338 patients diagnosed with ACE. The mean age in children was 3 and adults was 26.6. There was significantly more number of individuals with myopia in the adult onset group, and a total of 148 patients underwent surgery. The success rate in surgery was 73%, and success was better in the adult onset group, that is 75 to 66% in the childhood onset group, and they had followed these patients for around 12 months. So regarding the history and evaluation, we should note down the type of diplopia, the onset, that history regarding the hours of near activity, the duration of symptoms. Always better to look at photographic evidence before the said period of onset to see whether it's constant or intermittent. Orthoptic evaluation, including motor and sensory. Always see the ability of the patient to fuse with the prisms, because that will give an idea of the post-operative outcome that you may expect. And always rule out accommodative esotropia by cycloretinoscopy and prescribe glasses if so. So the criteria, as already stated, is acute onset with a comitant deviation. Comitant means there should be no difference in all the cases, and between near and distance there should be no disparity. You get a photographic evidence. Most of the patients have smartphones. You can actually see the period where it has started, and normal motility with diplopia. Imaging, better to do in all patients, because rarely it can be associated with intracranial etiologies. So the natural history, spontaneous recovery is unusual, but you can always advise the patient to stop all the near activity for a short period and observe. And there is excellent prognosis for binocularity if you intervene early. Differential diagnosis for this condition is acute 6-nerve palsies, divergent related distance esotropias or divergence palsies, accommodative esotropia. In all these conditions, you will find a near distance disparity, ocular myasthenia, and decompensated monofixation. So treatment, there are various treatments for ACE, including extraocular muscle surgery, botulinum toxin injections, prisms, and divergence training. But the gap between the onset of the double vision and the diagnosis and your treatment strongly influences the treatment outcome. So the main factors that determine a good motor and sensory results are good visual acuity at the time of diagnosis, younger age, and augmented surgery dosage. Whenever you plan for surgery, aim for a small exophoria, because that will make sure that you do not, the patient do not have diplopia post-operatively. Coming to the role of botulinum toxin, it can have many advantages, being less invasive. It's a non-surgical option. It results in faster recovery, and you can do this very early, like 1 month post onset of symptoms, whereas for surgery you may need to wait a little longer, especially in cases where you do not have stable measurements. So we have significant experience with Botox in our center, where the dose-related injection, the units depend upon the angle that we measure, and this is being injected under very short inhalational anesthesia in children and topical in adults, so it is like a OPD procedure. And in 47 patients that I have injected, a mean age of 10, you can see that many of them were presented less than the age of 5. About 90% had no systemic associations, and 51% of the patients had presented within 1 month of onset. And this was the dose. Most of them had a large and stable angle around 40 prisms. And if we see the success rate, if you quantify as final horizontal deviation of less than 8 prisms of ESO with diplopia relief, then we had success in around 59.57% in the 9-month follow-up with a single injection. And if we consider just as release absence of diplopia, then we achieved success in 79.5% of patients at 3-month follow-up visit. And so it is less invasive, faster recovery, good option, in variable angle, cost effective, and most of them, once they get them realigned, then they don't fall back into the esotropia. And post-operatively, post-injection, you also need to work on their divergence. You need to put them on exercises to improve their divergence abilities. So this was a study which was comparing with surgery. as success less than 8 prisms and sensory outcome stereo of 40 to 60, they found around 60 to 70% efficacy. And similarly, another recent study in August 2023 compared between botulinum toxin and surgery, and in their experience they had found about 73% success rate in the botulinum toxin group versus 97% for the surgery group. So that's all I have to say. Thank you.
Thank you, Dr. Sandra. That's a wonderfully detailed talk on AAC. And Dr. Jetani tells me that all this is being recorded and it'll be available on YouTube. If you want to refer in the future, I think it'll be an excellent resource. Thank you so much for that comprehensive talk. And you can, for the next talk, would you be ready?
We'll go back to the previous talk.
So, shall we move on to the next one then? Yeah, so as they're getting set up for his talk, Dr. Sinha, we'll move to the next one. We invite Dr. Sujata Guha to speak on non-surgical management of IDS. Does it have a role?
Good morning, everybody, and I thank AIOS for this opportunity. I'm going to speak on non-surgical management of a very common disease, of a very common strabismus that we have in our part of the country and our part of the world, that is intermittent divergent squint or intermittent exotropia. It's not moving. The slides are not moving. So the natural history of intermittent exotropia goes from exophoria to intermittent exotropia to constant exotropia. And it usually progresses with the age because of decreased tonic convergence, decreased accommodative convergence, and with age, there is increase in orbital separation, and there is a peculiar hemiretinal suppression which occurs in these patients, which causes the patients not to appreciate the diplopia and then have refixation fusion movements. So that is why it actually progresses. And if we can stall the disease somewhere in the exophoria or intermittent exotropia phase, we can avoid surgery. And all of us who have dealt with these patients and have operated on these patients know the pitfalls. There can be exodrift or recurrence. The younger the age of surgery, the higher the recurrence. It is very difficult to pinpoint and get correct angles. You tend to slightly overcorrect to avoid this exodrift, but if you have overcorrect more, then you can end up with microtropia and amblyopia. So you have often get undercorrection and end up with a challenging second surgery. So who are the ideal candidates where we actually think of non-surgical management? They are the young children, the smaller deviation, less than 20 prisms, and patients with good control. Coming to control, good control can be measured objectively by stereo acuity, better for the distance because that goes first and later for near, or you can have the Newcastle score where we have good, where we have home control and clinic control. Good control is when they don't notice squint 50% of the time. In clinic, good control is when there is immediate realignment after a refixation, after a dissociation, or they can realign with a blink. So how does non-surgical management help? It helps to reinforce fusional potential, to teach the control of deviation, to eradicate suppression, and to create an optimal sensory condition before you plan surgery. The modalities include correction of refractive error, overcorrecting minus, part-time occlusion, prisms, orthoptics, and botulinum. So if there is an uncorrected refractive error, the visual blur destabilizes fusion in intermittent exotropias. Whereas a clear retinal image improves sensory and motor fusion and also helps us in giving a correct angle of deviation. In myopes and astigmats, we correct fully. In hyperopia, we usually undercorrect to the extent of 1.5 to 3 diopters. If we undercorrect more than 3 diopter, it actually relaxes accommodation, and in higher hyperopes, you should not undercorrect too much because again it will cause a blur and it will defeat the purpose. Overcorrecting minus glasses had been fashionable a few years back. It is usually preferred in preschool children because older children may not accept the over minus glasses. It works by stimulating accommodative convergence and thereby improves control. How much do we overcorrect? Anywhere up to 1 to 3 diopters in increments of 0.5. We observe the control over the deviation, and it is very important to call them for follow-up. The first follow-up should be in 3 weeks to 4 weeks, and then thereafter in 3 months, and you assess the improvement in the NCS score. However, there are cons of over-minusing. They can actually develop myopia. In this day and age of myopia pandemic, we wouldn't want to do that. They can also develop near-esotropia or phoria and asthenopia. Part-time occlusion works by eliminating suppression, so it helps the patient to appreciate diplopia and thus have motor fusion. It improves stereopsis and it might decrease the angle of deviation, and it can help in postponing the surgery. We can do monoocular if you have a dominant eye, which it is usually true in these cases, or you can do alternate patching part-time in these patients. There are many studies in favor of these. Akbari et al., Al-Kahmouz et al. Observed good control of intermittent exotropia with part-time patching. However, the PD group did not find that. Orthoptics exercise has been tried for these patients. They work by anti-suppression training, correcting abnormal retinal correspondence, improving fusion, and usually it improves the convergence and achieves binocular single vision. Box strings improves convergence. Lifesaver cards improves free space fusion. The VTS4 software are used for improving vergence facility, mainly convergence. Aperture rule and Bernaloscope are all for improving the convergence facility. So which patients will show the best response to orthoptic therapy? They are the basic exotropes or the ones which has convergence insufficiency. They improve when you improve the convergence. And the ideal protocol that we follow in our institution is 1 to 2 times a week, 60 minutes each time, 10 sessions of in-office therapy, and we add that with home reinforcement 15 to 30 minutes per day for 5 days in a week, and this continues for about 6 months, and we call them for a follow-up and see whether they need more. Prism therapies, again, base-in prisms or relieving prism enhance bifoveal fixation by bringing the image out of the suppression scotoma. You can have overcorrecting prisms again to induce diplopia and stimulate fusional convergence. We have base-out prisms which can improve control sometimes in intermittent exotropia. Botulinum toxin can be given anywhere between 2.5 to 5 international units into the muscle belly, which is actually a little far from the insertion or from the limbus, and you can have adverse effects as globe perforation. So to summarize, we know that surgical intervention in intermittent exotropia at very young age has poor sensory and motor outcomes, and postoperative drift is common regardless of age. Non-surgical options give us a scope to postpone surgery, sometimes avoid surgery, and provide an optimal sensory milieu for surgical success. Thank you.
like to introduce the next speakers, Suma Ganesh on IDS, how to avoid and manage recurrence.
We can take the questions later.
What do you want?
Is it working now?
Constant.
Okay.
I think it's come.
So the peripheral organ, the
Yeah.
laptop was fine, and we thought that the optic nerve is gone, that is the channel. We tried to start with the brain, which is the central console. It didn't work there also. So we come back to the other channel, which is the right eye now. So the left channel is gone. So I'll be talking in brief about the amblyopia, and this is going to be a brief overview. I think most of us, we know about it, and most of us have been kind of following the ATS studies, all of them. So let's talk about amblyopia. Amblyopia is a reduction in the visual acuity of one or both the eyes caused by abnormal binocular interaction in the critical period of visual development. And there's no anatomical structural abnormality in the eye or the refractive error. So clinically, we define it as a difference between the two lines of two eyes, or none of the eyes reaching 6/9 or 20/30. And it's the most common cause of monoocular vision loss in children, amounting to approximately 3 to 6% of children. Now, types could be anisometropic due to blur of the image, strabismus because of the abnormal binocular interaction, visual deprivation because of absence of formed vision, or a mixed, which could be a combination of all of the above, or rarely reverse occlusion when we were practicing full-time occlusion. It could cause an occlusion amblyopia. The success lies in the early detection and the proper institution of therapy, because it has to be done when there is a cortical plasticity and the patient has not attained visual maturation. But we all know that sometimes even the adults can be treated for amblyopia. So is it just a reduction in the visual acuity? It's not. It's a visual function which has poor binocularity, abnormal contour interaction, reduced contrast sensitivity, positional uncertainty, spatial distortion, poor accommodation, abnormal eye movements, and suppression. Also, there are studies which talk about that the sound eye can get trauma because of the other eye being amblyopic. And here what we try to improve is the BCVA, binocularity, striopsis. If not all, at least some of them can be achieved. The idea in the present day's competitive world is to improve the BCVA, improve the confidence and personality of child, and make him fit for the competitive world and its future medical examinations. So counseling is the most important. We have to give chair time to the patient, make them aware of the time which has been lost and the time left to improve in the amblyopia. It's a team building effort. The optometrist who is giving the glasses, the ophthalmologist, and the parents and the caregivers, and child is an equal important partner. Child may cheat and re-cheat, so you have to counsel and re-counsel the children. And the toughest resistance we face here is from the grandparents, followed by the parents and then the children. So you have to counsel the parents and the grandparents also. Now, how do we achieve? The treatment options are the optical, the patching, the pharmacological penalization, and the dioptics, which are new. So optical is by far the most important, the first line of treatment. Correcting the refractive errors is the first and foremost thing. Give time for adaptation to the prescription of glasses, and at times we find that some visual improvement does come, if not full, with just giving glasses to the child. Patching is the gold standard, where the brain is forced to see with the amblyopic eye. Traditionally, we were taught the full-time patching, but then came the PDIG and the ATS with a lot of studies. So we went from full-time to part-time, which works 6 hours a day for severe amblyopia, and 2 hours a day, which is equivalent to 6 hours a day for moderate to mild amblyopia. Then we talked about the pharmacologic penalization, which is also looked upon. So again, it goes off. So atropine penalization, again, it was talked off by the ATS. So prerequisite here is that when you do the atropine penalization, even with the refractive correction, even with the penalization, the visual acuity of the worse eye should be better than the sound eye, only then it is going to work. So PDIC talked about weekend only compared to daily penalization, which is equivalent to patching in mild amblyopia. Now, dioptic treatment is a binocular treatment without patch or penalization. So it's a newer technology which has gained most interest. But we know that I think ATS20 had talked about that the dig rush did not work as good as patching. So they are all new forms of technology, may use red beam anaglyphics or polarized glasses. The common ones which are being used are the dig rush, falling blocks, eye bit, occlutab, binocs, and revital vision. So the clinic-based can have issues like the patient has to be called again and again to visits, repeated visits. They need monitoring by the optometrist. It's a difficult situation in Indian scenario because sometimes you have patients coming from very far off places. Also, there are limited games. After a couple of games, the child loses interest, which I have found in my kind of limited experience with the Oclutab, because we did try. But then the child used to say that this is not, kind of my kind of games, and they refuse to play, or they refuse to pay attention to the repeated games we're talking about. Home-based have come up in terms of, Binox and Digrush. They are more beneficial as compared to the clinic-based because they have many games. It's a possibility of online monitoring, and maybe in terms of they may be a little more cost-effective in terms of not imposing a cost of transit from the home to the clinic every time. Now, there are some magic claims, especially like this, which was sent to us a few days back. This was an email I think we all received. So this was an adult who was having a hyperopia in one eye and was given contact lenses and revital vision for about 60 sittings, that is 2 months. So, and I think most of us would agree that if you give optical correction and give 2 months of time, the child would probably improve, or an adult would probably improve from 6/12 to 6/9, even without revital vision. So weaning is an important part. It should be planned. A gradual decrease over a period of weeks, and eventually stopping in the hours of therapy is the kind of weaning what we do. So when do we wean? We wean when the child reaches 6/9 or 6/6, or the maximum VCVA has been achieved for about 3 months. It is again gone. So the important here is to make the child and parents aware of the regression, because it does occur in up to 20 to 25% of patients. And whenever this occurs, there should be a longer and slower weaning rather than a rapid weaning. Now, some tips like candies and toffees do help in building the rapport with the child because they are the most important partner in their treatment. Visual deprivation and strabismic amblyopias, you have to make aware that sometimes a full-time patching may be required if the part-time patching is not working for the child, and the parents and the child should be ready for it. For an isomyopes and aphakics, contact lenses along with the therapy works better if the glasses are not working for these patients. After completion of therapy, the follow-up is very important because sometimes the child do regress, and it is very important to pick up regression early and reinstitute the therapy early. So treating an amblyopia is an art rather than a science, and you have to choose the best suited part of treatment depending upon the severity and the type of amblyopia and the compliance and the ease of use in a particular patient. Thank you for your kind attention.
Ideas. Can we take the questions later? Yeah. So we'll go to the next topic. We invite Dr. Suma Ganesh to speak on intermittent divergent strabismus, how to avoid and manage recurrence.
Yeah, please keep all your questions ready. So we'll take them all at the end of the talks.
At the onset, I would like to thank AIOS for giving me this opportunity. Is it working? So my topic today is IDS, how to avoid and manage post-surgical recurrence. So patients with, I think, intermittent exotropia are most challenging because you do a surgery and they tend to exodrift over a period of time. So the reported incidence of post-operative exodrift within 2 to 4 years after primary surgery is up to 42% and 50% respectively. So this is responsible for the post-operative drift is responsible for the high recurrence and low success rate after surgery. So we need to, as clinicians, predict the time of onset and the rate of progression of exodrift after surgery. So we did a paper, we published a paper in 2017 where we wanted to assess the factors affecting residual exotropia after 2 muscle surgery for intermittent exotropia.
and it was done by a single surgeon, and we studied the factors. We compared the factors between patients with residual exotropia of more than 10 prisms and successful outcome within 10 prisms after 4 to 6 post-operative visit. So 27 patients, that is 17.2% patients, had residual exotropia at 6 weeks post-operative follow-up. And this was not affected by amblyopia or anisometropia or lateral incompetence, pattern deviation, vertical deviation, the type of exotropia or the type of surgery done. So what we found, the main factors were the age at surgery. The patients with an older age and a large preoperative deviation had greater chances of developing failure of 2 muscle surgery for intermittent exotropia. So there was similarly, again, a paper published in 2021, and they found the same thing, that there was a post-operative drift, exodrift of around 16.6%. So the recurrence is common. So we have to study the factors. So one factor is the large exo deviation. Most of us get patients very late, and they're already into phase 4, that is basic exotropia. So they have mostly come with, most of the time they might come with near deviation more than distance deviation. So we do a post-recess resect, and then we find there is a residual of around, still for near, there is a residual of 16 prisms. So patients with large preoperative deviations more than 40 prisms and who are in phase 4 or constant deviation had a poorer chance of successful outcome after a single intervention. So in many studies which have been done, so most of them have said the single prognostic factor, significant factor, was the angular deviation at the distance the first day after surgery. So even if we get a small residual exotropia at within the first 3 months, we need to observe them for at least 24 months. So I think what Dr. Sujata has presented very well, that we need to go rush in, and even if we get around a 4 or 6 prisms exotropia and we are very happy, like it's come to a good result, less than 10 prisms, we need to observe them and we need to push them towards binocular vision therapy. So small angle deviations of basic exotropia, they give better results because when you slightly overcorrect them during the immediate post-op period, they are found to prevent long-term recurrences. So how much to overcorrect will be like we normally overcorrect, but around 8 to 10 prisms of, we try to make them 8 to 10 prisms of esotropia. So they give you best results. So what they have found out, that one other study published, that what is the long-term survival analysis of bilateral lateral rectus recession. They found that it also varied by the type of surgery and the surgery done. So patients with basic type of exotropia did not do well if treated with bilateral lateral rectus recessions with either as patients with either true divergence excess or simulated divergence excess exotropia. So we need to choose a type of surgery when we see the patients, like in this patient, where we found that the distance was more than near, and it is a true divergence excess type with a V pattern. In this patient, a bilateral lateral rectus recession with upward transposition plus inferior oblique transposition helped, and this is the planning of the surgery. So this helps to prevent recurrences, and so we need to plan the type of surgery also depending on the case. But for a basic exotropia, the basic concern is that we have seen that the results are not very good. So what is more effective, a bilateral lateral rectus recession or a unilateral R&R? So there was a better survival probability in the bilateral recess group and lower recurrence rate. So a meta-analysis study showed that they wanted to study what happened when we did a bilateral lateral rectus recession or a unilateral recess resect. So there was a higher success rate with the bilateral lateral rectus recession and lower recurrence rate when the duration of follow-up is more than 2 years. So how to prevent or better treat patients with IDS? So age. So we should operate them much early. The best results are achieved when we operate them between 4 to 7 years of age, due to greater chance of post-operative bifoveal fusion. So we should not delay them, because most of the time patients are being referred only late. So we need to educate more and more the general ophthalmologists that they need to refer the children early, and we also need to operate in the phase 2 of intermittent exotropia instead of telling the patients to wait or the parents to wait. And the deviation should be measured when the patient fixates on an outdoor target. And monoocular occlusion can be achieved in patients with exotropia. You can do a monoocular occlusion to decide the amount of surgery. But a prism adaptation test is much better. We can use the Fresnel prisms, and we can determine the maximum angle of strabismus. So we can put the Fresnel prism, make them sit for 1 hour, and we can estimate whether they'll have a fusional potential, and also we want to know how much of the maximum angle of strabismus is there. So the preoperative PAT test, so whether it is better than the monocular occlusion test. So a paper was published in BMC Ophthalmology, and they found that performing preoperative PAT in patients with basic type of intermittent exotropia to determine largest exotropic angle gave good results. And deviation angle was increased after prism adaptation in 73% of patients, and the changes were great enough to affect the surgical number. So PAT is better than MO in unveiling mask deviation, and they also prefer that 1 hour MO is not very effective, so it is better to do a 1 hour PAT. So this patient with a 45 exotropia and with an OD suppression and with an absent studio. So the patient has come at the age of 25. So you plan a recess resect, but after 1 month, you get a residual deviation for distance and near. So you have operated well, but the only thing was a PAT was not done. Maybe a PAT would have improved the surgical success rate. So we need to push towards office-based therapy, which was nicely presented by Dr. Sujata. So we need to have them come for orthoptic sessions, office-based therapy. Most of them prefer a home-based therapy, but after 4 months and 10 sessions of OBT along with HBT, the patient did have stereo and a good NRC. So this will prevent your recurrences, and that is what is very important. Not just do a motor stability for the squint surgery and let the patient go. We need to focus on the sensory portion too. So binocular vision therapy and prisms has to be incorporated into your strabismus practice, because this is improving the sensory part of your strabismus. We can't just operate the motor part and say that everything is fine. So we need to look at the sensory portion. So surgical strategy on exotropia reoperation was nicely demonstrated by Dr. Edward Buckley's paper. And if you have done a previous recess resect, then you need to go to the other eye for balancing. And if it is a bilateral lateral rectus resections done with normal ductions, then you need to go for a medius rectus resections. So in this patient, we have done the other eye. There's a recess resect of the other eye. Now, sometimes we find that these patients come with multiple surgeries done, already operated twice, and she herself is a doctor, and they found that they're not able to function. So we need to, I think the important thing what I feel is that sometimes we operate and do not improve their sensory, and so they get what we call as a malignant strabismus, or that we have to operate them 3-4 times just to make them perfect. So we need to touch also the obliques, like in this patient, the inferior oblique was not touched, and so there was a left hypertropia and only the recess resect was done. And so we need to go back, and we should educate ophthalmologists that we need to touch the obliques and not leave it alone when you're doing a recess resect surgery. So in this patient, I had to go back and do, there was a scarring in both eyes, medial rectus was done, swan incision was done. We re-resected the medial rectus and the left inferior oblique, and also recessed the lateral rectus of the other eye because there was an incomitance. So I prefer to do the surgery in the right side. So other thing which can be done for residual strabismus is a recent transplantation technique. And is my time up? Okay. So so this calculation is done for medial where we can. So this small video for, I think I'll stop here. So transplantation is another technique where you can transplant a small portion of the medial rectus. So you put a non-absorbable suture in the lateral rectus. You have to recess it, and you transplant the medial rectus to the lateral rectus, and by that you will get a good result. So when cases were already operated 2-3 times and you have no other scope what to do, then this seems to be a very safe option and a very good option. Of course, in exotropia there are still residuals because the medial rectus which we dissect maybe come out to be very small. So small amount of medial rectus only you get for transplantation. And with that I close. Thank you.
Thank you very much. We'd like to invite the next speaker, Rebecca, for muscle transplant. Is it an answer for large strabismus? And it seems we are ahead of time, so there will be time for questions after the session, so please keep your questions for us.
So, very good morning, everyone. I think my job becomes a little easier because Dr. Suma has already given you an introduction to what a muscle transplant is. So, is it an answer for the large angle strabismus? That's my talk. So, let's first understand that what's a large angle strabismus. So, anything that cannot be managed by a routine 2 muscle surgery using the routine surgical dosages can become a large angle strabismus. So, give or take, it would be more than 60 PD, and that becomes a unique surgical challenge because you have limited treatment options. So, what are those? You can go for 3 or 4 muscle surgeries, but the reference table are mainly designed for the 2 muscle surgeries. Then, second option could be you could do a stage surgery, one eye, later on followed by the other, but the surgical cost and the hospital stay becomes higher for the patient. And if the patient is one-eyed, then there is definitely unwillingness for the fellow or the better eye surgery. So then what can you do in these cases? Well, you can do extra recessions, which is supramaximal recessions or hangback recessions. But there is risk of creating incompetence by doing these surgeries. There could be limitation of movement on extremes of gazes or alteration of the palpebral aperture width. People have also described augmenting recessions using botulinum toxin or spacers. And one such a good option which is available is a recession resection along with a muscle transplantation. So as Dr. Ma'am has already described, that what you do in a muscle transplant is that you are using the tissue which would otherwise have been discarded, the resected tissue. So I would say that it's a very, it's a very eco-friendly way of utilizing the tissue. You're not wasting anything. So you are kind of transplanting the tissue which would otherwise would have been discarded to the recessed side, and that is kind of adding to the recession. So that gives you an extra recession along with the spacer. So I have been doing muscle transplantations in large angle ESOs and exos and have achieved pretty gratifying results in most of them. So this is one example, a female patient, she has a large angle ESO, more than 80 PD, and we planned a resect procedure. So we did a LR resection, which is 8 mm. So we have to consider the contraction factor of the tissue. So the tissue contracts by around maybe 30% or 40%. So you get an effective spacer of around 6 mm. Maybe 5 or 6 mm. So you are adding to the recession of 6 plus 6. So approximately a 12 mm recession is what you are able to achieve. And this is the serial post-ops of the patient. As you can see, at 1 week, you see an overcorrection and a little hypertropia. So hypertropia is because we miss the inferior oblique overaction, and that can happen, especially if the strabismus is large. This overcorrection, I would say, you notice that the MR action is not fully recovered in adduction. So as you can see. Then wait for 1 month. At 1 month, you see that the overcorrection gets better, and the hypertropia is still a little evident, and so the adduction recovery. So the recovery movement on adduction improves. And this is the 3-month post-op of the patient, where you see that the patient appears to be pretty okay. A little hyperopia is not much of a botheration for the patient, but yes, the adduction limitation, as you can see, is -1. But I must tell you, this is one of the earlier cases that I was doing. So here I was dissecting a little less. But then I started dissecting a little more. I think you should dissect a little more than you would do in case of a normal resect procedure. So this is a similar case with a similar planning that we did in this, but of course with a better dissection. So this is the 3 months post-op of the patient. And as you can see that the patient is not only well aligned, there is minimal change in the palpebral fissure width. So this is pre and post. And also look at the limitation. It's hardly -0.5 as compared to the other side. So acceptable. So it's important, I think dissection is very important while you are planning or doing extra recessions or any supramaximal recessions. Now this was a paper that was published by Dr. Jethani and his team, and they have achieved a good correction of around 90 prisms and stable results for at 2 years follow-up in cases of large angle esotropias. Then coming to exotropias, this is a patient, large angle exo, you see an A pattern, there are bilateral superior oblique overactions. So we planned a transplant procedure along with bilateral PTSOs. So this is the post-op of the patient. Again, have a look at the serial post-ops of the patient. 1 week, the patient appears to be well aligned, but look at the limitation. So we are concerned about the limitation on the recessed side. So you see a little -1 limitation. At 1 month, it reduces, and at 3 months, it's kind of similar. So you see that the alignment, the palpebral fissure width, and the limitation of movement, it's all acceptable provided you have done a proper dissection. So this was a study that was published from a center by Dr. Amar Pujari, and he has achieved good results of correction of around 80 prisms in large angle exotropias using muscle transplant with minimal limitation in abduction. Now this is an interesting case, as Dr. Suma was just describing, that in residual cases of exotropia, you can attempt muscle transplantation. So this patient had undergone bilateral LR recessions around 6 mm in 2013, presents to us with a large angle exo. So there is a bilateral inferior oblique overactions as well. So we explored the LR. We found that the LRs are at 6 mm. So we planned a further recession to 12 mm from the original insertion, and we added the muscle transplant to this recession. So it kind of made a recession of around 16 or so, or even more than that. And this is the pre-op. So you see it's not fully corrected, but look at the marked correction that we have achieved. So it was around 100 PD before, and it's reduced to around 30 PD. So almost a correction of 70 prisms you have achieved with a single eye surgery, and the limitation is not that much. Now since this was a recurrent surgery, you may have scarring or fibrosis of the conjunctiva, and when you are planning such large recessions, you might have to also do conjunctival recessions. So in these cases, like I prefer to put a AMG, as you can see in the ASOCT image, because that helps in the healing of the ocular surface better. So if you look at the advantages, it's a unilateral surgery, can be done in single sitting, minimal limitation of ductions, minimal change in palpebral aperture, learning curve is simple, and there is no risk of graft rejection. In the disadvantages, well, it's a little tedious surgery, a little longer time than the usual recess-resect procedure. There are lack of standard guidelines and dosages, and of course, you have to keep in consideration the contraction factor that happens, because supposedly this is the MR recession that I did in a case. It was 6 mm. After you have resected the tissue, it shrinks immediately by 50%, so around 3 mm. But once you have attached to the recessed muscle, it further expands a little. So approximately a contraction factor of 30 to 40% is what I consider. And eventually the tissue is replaced by the fibrous tissue, but it's important that good muscle-to-muscle attachment must be obtained, and because that is the key to preventing any complications. So although there are no established guidelines, but this is one, the surgical dosage, that's a table that's available in a beautiful paper in JAPOS 2019, which you can use as an initial guide, and later on you can titrate your dose based on your surgical experience. So that's just a transplantation video, only if we have time, because I've already exceeded the time. So I'll just quickly run through it. So this, we are hooking the medial rectus muscle. This was being done for the large angle exo. So once you have hooked the medial rectus muscle, now key is that you need to dissect it carefully. You have to dissect a little extra. Okay. Sorry. I think it's, yeah, so once you have dissected, so then using two double-armed 6 or vicryl sutures, you need to pass it and secure the muscle fibers, just as you would do for a muscle resection procedure. But the extra step that you need to add is you need to pass another suture at the insertion. So that is also a 6 or vicryl suture. Then what becomes important next is to resect the tissue carefully, because you cannot waste even a single inch of a tissue. In fact, inch is too big a word. So you cannot, you just cannot afford to lose any tissue. So you have to cut it carefully, cut it out carefully. You see that the tissue immediately shrinks now. And then you put rest of the, just put the muscle back in position. You need to attach it to the original insertion, just like you would do for a resected muscle. And now going to the other side. Here we are exposing the LR. You need to nicely dissect it out. Again, you pass the sutures at the insertion just like you would do for recession. But remember, here we use a non-absorbable suture. So after you have disinserted the muscle, we take the mark. In this, it was planned to be at 9 mm. So we place the scleral marks at 9 mm. And then you attach this resected tissue, chunk of tissue, onto the recessed muscle. So you see that the muscle has already shrunken, the tissue has shrunken. Now this passing of the suture is really important, muscle to muscle attachment, to avoid any kind of a muscle slippage. You must secure this attachment carefully, pass extra knots if needed. And this lengthened muscle finally is sutured onto the sclera at 9 mm. So it's 9 mm of a recession along with that spacer tissue of around 3 to 4 mm. So that is the effective recession that you achieve. So that's how we are just passing the scleral sutures. And then you can close the conjunctiva using either the glue or the vicryl sutures. So I think muscle transplant is a good option, but you have to dissect it carefully. And in exotropias, now since the amount of tissue that's available for transplantation is very less, so you have to, while dissecting and kind of harvesting the tissue, you have to be careful. Thank you.
We'd like to introduce the next speaker, Subhash Dadaya. And the role of AIOCT in Strabismus in resurgery, so OCT of the anterior segment.
Very good morning to one and all. At the outset, I would like to thank the scientific committee of AIS for inviting me to speak here. I will be speaking on role of AIOCT in strabismus resurgery. Basically, role of imaging modalities in strabismus surgery is regarding understanding the etiology of strabismus, good surgical planning, and role becomes more important when previous surgical details are not available, to operate the same eye or the other eye, to know the exact location of the muscle, the status of resected muscle or scar tissue. Various imaging modalities which are available are CT scan, MRI, USG, UBM, AIOCT. Why AIOCT is superior? With wavelength of 1310, it generates two-dimensional imaging of high resolution from a reflected beam of light. There is faster scanning, less scattering, high penetration into the turbid structure, that is opaque cornea, sclera, iris, angles, non-contact examination, suitable for children and post-operative assessment, no radiation hazard, no need of anesthesia. So this is the machine which is available at our center, and no financial interest. So this technology was first used in 1991 to image the posterior segment of eye using a wavelength of 830, and in 2001 the wavelength was altered to 1310 to allow better penetration through light retaining tissues such as sclera and limbus in order to improve the visualization of anterior segment. These are the technical aspects. So identification of muscle on AIOCT: in unoperated eye, the muscle begins as a curved, thin, hypoechoic structure at the fixed distance from the angle, and this corresponds to initial tendinous part of the muscle, which when traced posteriorly, the corresponding hypoechoic area occupies progressively larger space, which further corresponds to the muscle belly. So the hypoechoic structure at a fixed distance from angle corresponding to initial tendinous part of the muscle is seen in this figure. The longitudinal scans provide length-wide details and cross-sectional sections provide width-wide details, and hence combined scanning is more productive than isolated scans. Medial rectus muscle identification. In recessed medial rectus muscle, the anterior ocular coat contour can be unremarkable and posterior ocular coat contour can show variable thinning. In resected medial rectus muscle, the posterior ocular coat might appear thicker and irregular with variable conjunctival folds. So this is the resected MR muscles confirmed by increase in muscle thickness at the insertion site. And the recessed medial rectus muscle was found at 6.7 mm from the limbus. For identifying the lateral rectus muscle, it is easy as compared to the medial rectus muscle due to more working space and absence of plica semilunaris and caruncles, whose shadow hinders the visibility of the structures. The recessed lateral rectus muscle show all well-maintained anterior ocular coat and disturbed posterior ocular coat. In resected lateral rectus muscle, the bulky insertion site can be noted. This is the AIOC2024 image showing the insertion of lateral rectus from the limbus. So what are the errors which can be there in muscle identification? Post-operatively, the muscle imaging needs to be cautiously judged till 4 weeks because the muscle space often erroneously appear as large hypointense layer which settles over a period of time with resolution of edema and conjunctival flattening. The large caliber conjunctival vessels can hamper and they can be judged as muscle areas. This can be avoided by carefully observing the muscle specific characteristics, and in presence of dense conjunctival folds or scalp, there might be some problems regarding the identification of the muscles. The identification of thin tendons and belly can be difficult sometimes, hence in these areas a correlational scan between longitudinal and horizontal scan can be considered for better clarity. Identification of muscle inserted more than 10 mm from the limbus cannot be identified in the AIOC2024. So this was one 17-year-old male patient, and there was a case of resurgery, and these are the preoperative and post-operative photograph of the same patients. In AIOC2024, the medial rectus was found at 7.8 mm, and with intra-op handheld caliper, it was found at 11 mm. On the other side, the AIOC2024, the lateral rectus was found at 6.39 mm, but when we measured it with the caliper, it was found at 7 mm. This is second patient. This was case of residual exotropia with V pattern. These are the pre and post-operative photograph. AIOC2024 was done, and MR was found at 8.7 mm, and with caliper it was found at around 10 mm. The lateral rectus was found at 13.5 mm, and with caliper it was found to be at 14 mm. This is another case, residual exotropia with V pattern, pre and post-op photographs. And when AIOC2024 was done with medial rectus, it was around 6.7 mm, and intra-op with handheld caliper it was at 7 mm, and lateral rectus was found at around 9.4 mm. This is another patient with residual esotropia. When AIOC2024 was done, medial rectus was at 9.45 mm, and intra-op with caliper it was found to be at around 10 mm, and lateral rectus was found around 8 mm with AIOC2024 and around 8 mm with the caliper. This is another patient with residual exotropia, and when AIOC2024 was done, MR was found at around 7.7 mm, and when we measure it with caliper, it was around at 8 mm. AIOC2024 lateral rectus was not well appreciated, and with caliper it was around at 13.5 mm. This is another case. In AIOC2024, it was around 8.7 mm. With caliper, it was around 11 mm. And AIOC2024 lateral rectus was found at 10.8 mm, and with caliper also it was same. So this is another case of consecutive exotropia. These are the pre and post-operative photographs. And when AIOC2024 was done, MR was found at around 7.9 mm, and with caliper it was around 8 mm, and lateral rectus was found at around 7.5 mm, and with caliper it was around at 8 mm. So the extraocular muscle insertion site is treated as a reference point in calculation of amount of strabismus surgery. Since prior strabismus surgery can alter the insertion point of muscles, a careful preoperative evaluation is mandatory, and AIOC helps to design a surgical plan by localization of displaced extraocular muscle insertion. In a study done by Kaur et al., and the muscle insertion could be identified in 12 cases on AIOC and 10 cases on UBM, and maximum insertion distance on AIOC was 13.8 and on UBM it was 10.4.
Yeah.
And in another study done by Dr. Amar Purzari et al., they concluded that preoperative AIOC can provide reliable muscle details with respect to its type of surgery and amount of surgery. The strength of study were practical role of non-contact imaging, highlighting features of recessed and resected muscles, and imaging and deeper penetrations. Limitation was small sample size, lack of universal landmarks, and lack of measurement of actual distance. So to conclude, AIOC with its advanced scanning ability can be utilized to locate extraocular muscles locally. It is really available for preoperative assessment of UOM without additional expense and can be performed even by adequately trained technicians well versed with the procedure. And this cross-sectional imaging tool can reliably be used as interrogative tool or a surgical guide while planning surgery in routine as well as in complex cases. Thank you.
Thank you, sir. I would now like to invite Dr. Sonal for her talk on red flags and seemingly common strabismus.
Thank you so much, Jitendra, for the introduction, and thank you for the audience, and thank you to the scientific committee of AIOC for inviting me to give the talk. Could I have the... So the topic was given to me was red flags in seemingly common strabismus, which is interesting because, you know, we have very busy, hectic clinics and the patients are just passing by one after the other. So my objective here would be to share two cases where we would want to look out for the red flags and then decide what to do next. So this is a regular patient who walks into your clinic. We've had a lot of exotropia being presented. This is a gentleman with a large angle V exotropia, 45 prism diopters with a V pattern with bilateral inferior oblique overactions. He underwent muscle surgery for the obliques and the exotropia, and he did very well. He comes back to our clinic 15 years later, and he says, my eyes are drifting again. He tends to prefer left fixation, which was the original left fixation again. And he again has a large angle exotropia, which was just the same 15 years ago, which is a little bit atypical, but it can sometimes happen, and there's absolutely no control of his squint. So what's happening here? Let's take a look at his video, because this is what we do in the clinics. We have a quick cover test, and we start seeing the eye movements. And here you have, so it looks reasonably okay. And we look at him in up gaze. There's still some V pattern there. We did have, so now let's see what's going on. Okay, that's the same video again, sorry. So here you have him in a still shot. And when you take a little closer look, you may notice that, of course, there is that large angle exotropia. But on lateral gazes, if you notice, abductions are full. But there seems to be some limitation in adduction. Now, remember, this was done 15 years ago. I didn't have access to the notes because we had converted to EMR, so we had to go to the storehouse and get his paper notes. So obviously, the first thing I got knots in my stomach was, you know, maybe the medial rectus, which I had done, has kind of slipped over time and causing this reduction in adduction. And once again, when you see that there's a limitation in eye movements, you want to quantitate further with ductions. And here you are, we can see the adduction in the right eye is limited. And the adduction in the left eye is also limited, though it was right more than left. So what is going on over here? Could this be iatrogenic? That's always the first thing which comes to our mind because we've done a surgery for him. We couldn't quite remember if the surgery had involved the medial rectus. If it did, then most likely the adduction deficit is probably from a slip muscle, loose pole, maybe a stretch scar. And if it's not iatrogenic, then we are a bit more worried. So let's now, finally, we got the notes. We noted that we had done a bilateral lateral rectus recession of 8 with bilateral inferior obliques, and the medial rectus was untouched. In a way, you breathe a sigh of relief, but then again, you're worried because now what is going on? Could this be iatrogenic? No, this is not iatrogenic now because the medial rectus wasn't even touched. So let's now re-look at the video again. So once again, take a look now and see what is happening to that adduction in the right eye. You can, there's an adduction lag, and there was an abducting nystagmus. Would you like to see the video again? So right eye adduction lag with a left eye abducting nystagmus. Okay, so now already majority of you in the audience have begun to know that is this incomitance worrisome? Of course, it's an immediate red flag. Okay, we had to send for a neuro-ophthalmology consult. They did extensive tests, which included imaging. And the MRI showed that there were these hyper-intense lesions along the periventricular white matter. And we saw the classical Dawson fingers, which are signs of periventricular demyelinating plaques along the axis of the medullary veins and perpendicular to the border of the lateral ventricle or the callosum. And this is classical, as you know, of a demyelinating condition or a multiple sclerosis. It's a bit atypical. We don't see multiple sclerosis as often as in the West. In Asia, and the gentleman was only 30+ years old, so rather atypical. Lessons learned is please pay attention to the motility pattern, especially to duction deficits, which can be very easily missed in our busy clinics on a quick cursory examination. Next case now is a 36-year-old gentleman who comes to us with horizontal and vertical diplopia. And here, true enough, he has a esotropia, he has a hypertropia. He seems to be proptosed bilaterally, but then in Asia, there's myopia. Singapore is the myopia capital of the world, okay? And we also have a lot of thyroid going around, okay? So ESO, hypo, and here he is on lateral gazes, and here he's on up gaze, so there's some limitation of abduction, there's limitation of elevation. So here we are going to share the video with you. And I've used a Spielman purposely just to let you see what's going on undercover. There's a hypo, there's a ESO. Okay, and then we go on to his eye movements. Some abduction deficit there. A little bit more on the left. And let's see what's happening on up gaze. I'm trying to ask him to look up. And there's a hesitation to up gaze. So the next thing we would like to do here is we used an optokinetic drum to try to simulate and stimulate an upward saccade. And here you can see there's an optokinetic drum which is rotating vertically in front of him. And all of you can see what's going on over here. There's a bobbing. Would you like to see that video again? Yes, okay, so. This is in response to an optokinetic drum trying to elicit upward saccades. Okay, so you can see that the eyes are converging, and there's a convergence kind of a nystagmoid movement. So what next would you like to do? Any guess from the audience? We want to check the pupils. Okay, and I'll show you a video of the pupillary eye exam. So we are just checking the pupillary light reaction. This is for light, which is for distance, of course. You can see the pupils look a bit dilated and do not want to react. And now we are showing him a near target, and we are asking him to read. And there you can see that you can see the constriction. So in addition, there was a reduced convergence. You have your big red flag waving around over there, and true enough, this was a Perinaud's dorsal midbrain syndrome. Okay, and he went in for surgery, he was shunted, and the histology turned out to be a pineal gland germinoma. So in summary, red flags are fellow travelers. Keep a lookout for them. Look out for incomitance, duction deficits. Look at the lids for retraction, ptosis, changes in the fissure. And last but not the least, please remember to do pupils in all our strabismus patients, look for accommodation deficits and light near dissociations. Thank you so much.
And the next speaker will be Sarah Jain for the keynote address on botulinum toxin in childhood strabismus. Please.
Thank you very much, John. Thank you to the scientific committee for inviting me. It's a real pleasure to be back in the city of joy. It's been so gratifying to see such a large room allocated for pediatric session. That always makes me happy. And it's really great to see the other talks, and especially the muscle transplantation, really fantastic. I'm going to talk to you about something a little bit different. And I don't know if you already do this, but I found botulinum toxin to be quite useful in childhood strabismus. So I'm just going to present to you some cases. And the good news is I can stop whenever my time is up because they're just cases. So, right. So, botulinum toxin is something that's been around not that long, actually. It was only licensed in 1989 by the FDA. So we use it, as you know, in adult strabismus quite a lot. I won't bore you with the pharmacology, but just to say what it does, it blocks the release of acetylcholine at the pre-transmitter level. That's what toxin does. Okay, it comes in various forms. So in the UK, you can have Botox, which is about 250 pounds a vial. You can have Dysport, which is cheaper, and you can have Xeomin, which is cheaper still. And our trust very much would like us to use Xeomin, but I use Botox. You reconstitute with saline. One thing I tell the residents always, never shake the bottle, because if you shake the bottle, you denature the protein. So try not to shake the bottle. Remember this graph because it will come back to haunt us a little bit later. And this is the pharmacokinetics. So when you inject toxin, nothing happens on that day or the next day. It only starts working in 2 or 3 days. It peaks in 2 or 3 weeks, and it slowly goes away in 3 or 4 months. Okay. So this is our first case. It's an 8-month-old boy which has a big esotropia noticed soon after birth. No other concerns. Okay. Fixes and follows very well with each eye, no limitation, large infraoblique overactions, big esotropia. So for the more junior members of the audience, this of course is an essential infantile esotropia, which has these features. It's always in infancy, as the name suggests. It's a moderate to large angle. They cross-fixate. They have manifested in nystagmus, DVD, infraoblique overaction, etc. This is a very typical. Now, although this case is typical, we still don't know why it happens, and there are two competing theories. So the Claude-Worth theory says, actually, your arch is not complete. You don't have the keystone. You don't have the ability to fuse. So it doesn't matter where your eyes are. You just cannot fuse. Okay? The Shew's theory says, well, actually, we think the problem is motor alignment. If you could take the motor alignment back to where it should be, maybe you will start fusing. And they are very opposing. In the UK, we very much tend to side with Claude-Worth. So we tend not to go in for early surgery for these patients on the whole, okay? But what are the treatment options? Well, there are many, and whenever there's many options to treat something, it means there's no one good option. So you could just watch them, okay, correct the refractive error, which they don't usually have, or you could operate early, so you could either do a bimedial recession or a recess resect. Now, the studies have shown that the results of bimedial and recess resect are the same. I personally prefer bimedial because it's a symmetrical procedure to both eyes. You're just recessing a muscle, so you're not losing any tissue, and if it all goes wrong, you can always re-advance it, right? We prefer to do a hangback because, again, I have a lot of residents, and it's much better suturing anteriorly where you can see what you're doing, but I think to fix the sclera is actually a very good technique, and you get less inflammation because you leave less vicryl behind. And toxin is just another addition to our armamentarium for this condition. So study after study has shown that early surgery does improve stereoacuity outcomes. The early surgery is defined by people. Essentially, it comes down to less than 18 months, probably less than 12 months. Okay, and that's what most people would understand by early surgery. And to be honest, at least in the UK system, we don't get to see them before this time. So why the hesitation? Why are we still talking about if early surgery is such a good thing to do? It's because the ocular alignment instability is common. Up to 50% of them, you don't actually know where they're going to end up. We also know that the rate of resurgery can be quite high, up to 50% in the next 5 years. up to 2/3 of them in 10 years if you include the oblique. So I think there's something to just counsel the family about. So in the ELIS study by Herb Simmons, he showed that the children operated early had better gross stereopsis at the age 6, but they did need more operation. That's really the takeaway message from this slide. If you do early surgery, you have a higher chance of them needing a second procedure. Okay? So in this scenario, I think toxin is a good halfway house. Okay? I do it under general anesthetic. I use the same kit as I use for the adults, the same EMG machine. Ideally, you want them lightly anesthetized, but ideally you also want them sitting up or slightly sitting up because you don't want to affect the lid to cause ptosis. And one of the key things I've found, if you leave the needle in for about 90 seconds by the clock, you reduce the incidence of postoperative ptosis because there's less leakage. This is the Mendonca forceps you can use because it actually grasps the tissue, and you can use that to inject it instead. We don't have one in our center, but I've heard all about it from the forum, so I wonder if any of you have any experience with that. Okay, this is our child, this is post-toxin, and this is what you want to see at 2 weeks. You really want to see an exotropia because you want to reset the dynamic oculomotor system to see if you can get the deviation better. This is another child of mine who just needed toxin, actually needed no other surgery. So which children does this work for? Who are the best children to perform this procedure on? If you look at the literature, this is the largest study by Alejandra Campomanes and Jill Benibom, and they looked at almost 450 patients, of which 322 received toxin. 50% of them, just one injection. 50% had 2 or 3 injections, and they used 5 units for less than 50 diopters, 7.5 for more than. And this is their cohort. Now, the interesting thing in this cohort is the toxin injection group was significantly younger. They presented earlier, which is why I think there was a hesitation towards surgery because of the ocular deviation instability we talked about, and that's maybe why they had the toxins. There's a bit of a bias built in the groups, but as you know, controlling in strabismus is almost impossible. RCTs in strabismus are so difficult for that reason because, as you know, every person is different. And this really is the key statistic. Okay, they found if your deviation is more than 30 diopter, you're probably better off having an operation. If your deviation is 30 diopters or less, toxin was the same as surgery. And that's interesting, and that might be something you might help to guide use. It's not to say you should not use toxin in children with a bigger angle. We have used toxin in children with big angles to reduce the angle to something that will need only 2 muscles rather than 3 muscles. So there is a role there as well. This is a really good meta-analysis of all the studies on toxin in infantile esotropia. And essentially what it says is the group success rate, success being here 10 diopters or less, is about 76%. Mean number of injections is 1.4. It was interesting. Higher the dose injected, lower the success rate. And I think this is because the higher the dose injected was in the children with higher deviation, which is why the success rate was less. Also interestingly, EMG guided injection was the same as open sky. So I don't think there's any point in opening of the conjunctiva, because you might have then just do the operation. So the whole point is to be non-invasive. So EMG is the same as open sky. They're significantly better without using EMG. They had a bit of ptosis, but a lot of that got better. Okay, and one of the things they noticed was tonic pupil, which can happen from time to time. This is my second case. Okay, there's an 8-month-old boy, again a large angle esotropia, but what's different here, he has developmental delay secondary to periventricular leukomalacia, and the parents are very keen on treatment. Now you have to be a bit careful in these patients because a lot of children with developmental delay can go on to develop consecutive exotropia. So we always a bit hesitant to offer surgery in this age group, and a lot of them require more than one procedure. However, you do not underestimate the psychosocial impact of a child with developmental delay and a large esotropia, and the parents were keen that he look as normal as possible in their words. So what we did for him, we just offered him toxin, and he had 1 toxin injection. This is him just 3 weeks later. You can see the ptosis, he's lifting a chin up. That's a good sign. You know, he's trying to use both eyes, and this is him 2 years later. So he had a really good alignment, and I felt that I wasn't scarring his medial recti without giving him the chance of the consecutive exotropia. So we actually collected all our cases and published them a few years ago. Okay, this is my third case. This is a 14-year-old girl and we already heard a fantastic talk about this. She had an acute onset of esotropia with double vision, and this is what she looked like, right? She didn't show the esotropia very well at all, but she had a sudden onset ET, about 30 diopter, lost her stereopsis, and the family was very concerned. We did neuroimaging, of course, which didn't show anything at all. We already heard about actually the 6 types, but these are the 3 most common A and AET types, the Swan type, the Franceschi type, and the Bilchowski type. And in this girl, we felt we do need to do something. She's probably the second, the Franceschi type, because of low hypermetropia. And again, you can operate or you could do toxin. So in this case, we elected to do a toxin, 2.5 minutes into each muscle under EMG. Now, it's really important you warn the family they're going to have an exotropia, because there's a lot of phone calls and tears that happen when suddenly the child's gone from in to out. But she did really well, and she regained her stereopsis. This is the next case. This is the one we also published in JAPOS. This was a 3-year-old boy, and mom kept noticing intermittent turn of the left eye. Now, camera phones have been the biggest boon, I think, in pediatric ophthalmology, because people will always have pictures of their children. Okay, so that for us has been, and she would say, sometimes it's there, sometimes it's not there, and she's right. Some days it's there, some days it's not there, and we got her to actually do a diary. She did a diary, she did good day, bad day, good day, bad day, and you see, it's a 24 to 48-hour cycle, so it's a good day, bad day, good day, bad day. So this is, of course, on the good day, when he comes, he's straight. He's got stereo, no problem. On a bad day, he's got a big onset ET with no stereo at all, okay? So in this child, we offer them 2.5 units to each medial rectus. He got a big consecutive XT, which I like. I'm quite happy to see that consecutive XT because I feel I've got the toxin where I wanted. 8 weeks later, intermittent XT, 6 months later, all gone. And he's not had a recurrence since then. So it can work in cyclical esotropia. And again, why choose toxin over surgery? Just because there was a bit of hesitancy, because the angle was changing, the family was not keen on having an operation, which I absolutely understand. So this is another rare form of strabismus, which is 48 to 24 hours cycle. In some of them, the manifest phase will increase over time, and they go into a constant squint, and then fair enough. I think then surgery and toxin have an equal role. It's just in this case, we felt if we could break the cycle, we might keep him straight, which we managed to do, and he's done very well. This is another child. Now, either she just has one frog, or they send me pictures on the same day, but she does have to have a straight day, and then suddenly she says, I see 2. Okay? So she had the cycle. She actually had surgery because I felt she was getting more and more manifest over time. There's another patient who flew all the way from Hong Kong to London to have a toxin injection. I felt like a bit of a fraud, but this is, so it's very difficult actually to see because of the epicanthic fold, but she's straight and then in, and that she has a slightly shorter cycle. So cyclical esotropia is difficult to manage. You can observe them, you can use toxin, or you can use surgery. And surgery, bimedial recession is the same as recession resection. If you're going to operate for the full manifest angle, and that's the key message here. Okay, this is my last case. This is I still have PTSD. So this is an 8-year-old girl. It started off really nicely. 8-year-old girl, intermittent XT. I said, I know what to do here. She's decompensating. I'll do an operation. She'll be fine. Everybody will be happy. She's got good stereo. We did the operation. So I did a recess resect, 7.5, 6.5. Done with my fellow, no problem at all, uncomplicated surgery. 6 days after the surgery, extremely unhappy. No more double vision, but the face is turned to the right. And why? Because she has a massive limitation of abduction and a massive consecutive esotropia. So, and no stereopsis. So, a lot of reassurance. This will relax out. Don't worry, it'll be okay. It's 4 weeks now. Now, the granddad is coming to the appointment as well. Lots of tears. As the mouth hospital says, she's very frustrated at the moment and very concerned about her child's well-being because of this. And now the ET has gone. It's gone from 40 to about 16, 25, but there's still this big limitation. So what do you do? Okay, has the lateral rectus slipped? Should you pull it up? Can you do something else? So because there was a lot of familial concern, and now we have 4 weeks and nothing's happening, we did some toxin. So under anesthesia, I looked at the lateral rectus. It looked like it was in the right place. So I did some toxin. 1 week post-op, great. Now everybody is happy. 4 base in, stereopsis is back, great. But you remember that graph I showed you, right? 2 weeks. This is what happens in 2 weeks. And now she's got an exotropia. So now the family is like, why can't you get it right? Now we're going the other way, now she's turning the head the other way. And you can see here that big impact of the toxin to the right medial rectus. And all you have to say is reassurance, it's okay, this is what's supposed to happen, it will be fine. And it was. 6 months post-injection, its child's happy, mother's happy, we're back to 85 seconds of an arc, and the exophoria is well controlled, and she's now firmly discharged, although I see her at the station from time to time, they wave at me. So just to recap, I think toxin, think of it as an armamentarium to treating small angle infantile esotropia in children with developmental delay, consecutive exotropia or esotropia, acquired esotropia, and you can use it in adjunct to surgery for 6 nerve palsy or rarely in exotropia. Thank you very much.
Thank you. That will end our session. Any more questions for the audience, or for the speakers?
In the interest of time, I think questions have to be taken perhaps later outside the hall.
One or two questions.
Maybe one or two questions, because we need to hand over the hall to the next session.
Question for Dr. Suma Ganesh and for the panel. She mentioned that the outcome of intermittent exotropia was worse in patients with older age group. So I wanted to know the opinion of her and the panel. Do you modify your surgical dose based on the age? So for example, you would increase the surgical dose in older age groups?
Questions for you. I couldn't hear. She can answer from there.
Thank you. Yeah, so the dosage of surgery, that's what you're saying. So when it is like the age group of around 4 to, in the age group of 4 to 7 or 4 to 14, you can say, then I would overcorrect. So I would overcorrect. I think I mentioned that 6 to 8 prisms of esotropia is my target. But later on, after that, I would mostly do a PAT in older age group. I would prefer to do a PAT and then see whether there is any diplopia post-operatively. So that is what I will aim at. So I would not aim in those esotropia, overcorrection.
Yeah, we'll just have a group photo before we close this session. Yeah.
Come up quickly for a group photograph. Thank you.
Dr. Ankur, Dr. Subhash, Dr. Suma, Sujata ma'am.
No.
Pediatric, yeah, because
operations. The problem is, I think if you work in the private sector,